Good evening, everyone. Today I'm going to present a class on trabeculectomy and its complications, and the class will be moderated by Dr. B. Shantha ma'am. So, what is trabeculectomy? It's a filtering surgery in which a fistula is created underneath a partial thickness scleral flap through which a aqueous passes from the anterior chamber into subconjunctival space, resulting in the formation of a conjunctival bleb in an effort to lower the intraocular pressure. So, what is the mechanism? By creating an opening or a fistula at the limbus allows a direct communication between the anterior chamber and the subconjunctival space. This fistula bypasses the trabecular meshwork, Schlem's canals, and collecting channels. Earlier, it was thought that the aqueous flow into the cut ends of the Schlem's canal, but subsequent studies showed the fibrotic closure of the canal at its cut ends in monkey as well as human eyes. The fluorescent angiographic study shows that a primary route of external filtration is in and through the margins of the scleral flap. Other possible mechanisms may be aqueous outflow through the newly developed aqueous veins and lymphatic vessels or through the normal aqueous veins. So, what are the indications? The indications are when the intraocular pressure is not adequately controlled on medications, or if there is a significant barrier to using medications regularly, like cost, compliance, and ocular and systemic side effects. Also, if there is a progressive visual field loss or a optic nerve damage, even if when the patient is on the medical management. So the pre-op workup and evaluation. So we have to go through the systemic history, ophthalmological history, ophthalmological examination, and patient expectations. In systemic history, we have to know about any the systemic illnesses, the use of anticoagulants and antiplatelet drugs. If the patient is using anticoagulant drugs, then we have to consult a cardiologist to stop aspirin and anticoagulant 5 days prior to the surgery. In high-risk patients, heparin can be changed to low molecular weight heparin, and all anticoagulants can be resumed day after surgery. For the ophthalmological history, we should look for is there any previous ocular surgery done. In topical medications, we should stop pilocarpine at least 2 to 3 weeks prior to the surgery, as pilocarpine increases the permeability of the blood aqueous barrier, thereby increasing the post-operative inflammation, which in turn can hasten the BLEB failure. We should also look for the medication that affect the ocular surface and disrupt the blood aqueous barrier, and they should be stopped 1 week prior to the surgery. We should also watch out for the chronic conjunctival inflammation due to brimonidine and topical carbonic anhydrase inhibitors, and conjunctival hyperemia due to ROCK inhibitors and prostaglandin analogs. In the ophthalmological examination, the anterior segment should be thoroughly examined under slit lamp to assess the lid hygiene. Conjunctiva should be assessed for prior surgery or any scar. Pre-op visual acuity should be measured. IOP should be measured using Goldman ablation tonometer. Syringing should be done. Conjunctival swab should be done in one-eyed patients. Detailed fundus examination and investigations like visual fields should be done. Patient expectations and proper consent should be proper informed written consent should be taken prior to the surgery. On the steps of trabeculectomy, adequate anesthesia is required. It can be done in local anesthesia as well as general anesthesia. Usually under periverbal anesthesia, the trabeculectomy is performed. The complications that can occur during local anesthesia are acute retroverbal hemorrhage, subconjunctival hemorrhage, or a globe perforation. In acute retroverbal hemorrhage, there may be a proptosis associated with hardening of the eye, discoloration of the lids, and elevation of the intraocular pressure. It can be managed with IV mannitol, which can be given in 1 milligram per kg body weight of 20% solution. In severe cases, lateral canthotomy with lateral cantholysis can be done, and the surgery should be deferred till complete absorption of the hemorrhage. These are the certain photos of the retroverbal hemorrhage.
Go back to the previous slide. So he's written subtenance block. One of the fellows, what are the disadvantages of using a subtenance block for trabeculectomy?
At the injection site, it may cause conjunctival buttonholing or bleb leak.
You're going to give the subtenance block inferiorly, not at the area of the surgery. It's a parabulbar block basically that he's talking about. You can give a parabulbar block inferiorly. Yeah, but there is a chance of subconjunctival hemorrhage there, but usually it stays localized to that area. But what is the other problem if you just give a parabulbar block alone?
Ma'am, extraocular movements won't be neutralized only.
Yeah, no extraocular movements. Yeah, that is one reason. But what problem will it cause? Extraocular and no.
Exposure.
No, you can ask the patient to look down and perform the surgery. You can put a traction suture. See, when there's an inadequate block and ocular movements and the orbicularis oculis movement is there, when the patient is squeezing the eye, there's a risk of a choroidal hemorrhage. So that's the reason why we usually prefer a proper block, a peribulbar block, or at least a inferior block and a medial conal. In certain situations, you can do the surgery with the parabulbar anesthesia. There's some contraindication to giving a peribulbar block. But this is one of the issues. It can be done, but if there is insufficient akinesia, you may have a choroidal hemorrhage in those who are susceptible.
Now, exposure. A good exposure is essential for the successful glaucoma surgery. So the first step is go using an appropriate eyelid speculum, which not only separates the lids but lifts them from the globe. The second is a traction sutures, which rotates the globe downwards and providing a good exposure. We can use either a superior rectus bridle suture or a corneal traction suture. So superior rectus bridle suture, the technique, we use a closed Dastur forceps to slit into the superior fornix, where it is opened and pressed firmly on the globe, and the superior rectus tendons is grabs, which is usually 7.5 mm behind the limbus. Then a 4-0 silk bridle suture is placed under the tendon, and the suture is drawn superiorly and clamped on the drape. There are certain complications associated with it, which are subconjunctival hemorrhage, conjunctival defect, scleral perforation, as well as postoperative ptosis. In corneal traction suture technique, the 7-0 silk or Weichel suture on a cutting needle is passed through the peripheral cornea, approximately 1 mm from the limbus for 3 to 5 mm of half to 3/4 depth of cornea and is attached to the drape over the cheek. It has its own complications like distortion of the cornea and anterior chamber distortion. Now the preparation of the conjunctival flap. The conjunctival flap can be either a fornix-based flap or a limbal-based flap. Several studies have compared the limbus and the fornix-based conjunctival flap in association with trabeculectomy and reported similar success rates. In a fornix-based flap, the incision is made at the limbus. It is usually easier and faster. It provides a good exposure, and the area of dissection is smaller. The BLEB formed is diffuse with a posterior drainage, and there is an easy placement of releasable sutures. It can lead to leaks are usually common in the early postoperative period, which was found in one study. In the limbal-based flaps, the incision is usually made 8 mm behind the limbus. It is difficult and usually takes more time. A larger area of dissection is needed. A BLEB may become cystic with a ring of steel. It is difficult to place the releasable sutures, but it has a watertight closure. So this is a video of a fornix-based flap in which the incision is made at the limbus. And then blunt dissection is done. So during this step, the complication which can happen is a conjunctival buttonhole. The tear may be due to a poor visualization or inappropriate use of the instrument. It may be increased in a previously operated eye. It can be prevented with use of gentle handling of the tissues as well as blunt dissection. And in managing this conjunctival buttonhole, the most important step is the immediate identification that the buttonhole has occurred. With small holes, the tissue can be puckered together in a figure of 8 or a mattress suture, and in larger tear requires a running suture, and a trabeculectomy should be done at a new surgical site. It is, if not noticed, conjunctival buttonhole can present as an early postoperative wound leak, and they may lead to hypotony, shallow anterior chamber, and scarring of the BLEB. Also, an early postoperative wound leak was also found to be a risk factor of failure of trabeculectomy in the FFSS study. The next step is cautery. So minimal adequate subconjunctival and episcleral hemostasis is essential to prevent healing response triggered by the blood. Excessive cautery should be prevented as it causes scleral shrinkage and conjunctival burns. Now the antifibrotic used in trabeculectomy, they are used to prevent the BLEB failure by modulating the wound healing process. Corticosteroids were the first to be used, and in recent times 5-fluorouracil and mitomycin C is the commonly used antifibrotics. There is a Moorfield-Moorflow anti-scarring regimen in which they divided the patients into low-risk patients, intermediate-risk patients, and high-risk patients. The low-risk patients were the patients which had no risk factors or a minimal topical medications like beta blockers only, all elderly population. In intermediate risk population, it was who have chronic topical medications, have previous cataract surgery without conjunctival incisions, And high risk patients were like patients with neovascular glaucoma, chronic persistent uveitis, previously filled trap or tube, aphakic glaucoma. And according to the regime, the low risk factors, either intraoperative, we can use no antifibrotics or 5-FU with a unit of 25 to 50 milligram per ml. Or in intermediate risk, mitomycin C can be used of 0.2 milligram per ml. In high risk, it can be used for 4 milligram per ml for 3 minutes. 0.4. Now, moving on to the mitomycin C and 5-fluorouracil. Mitomycin C is an antineoplastic antibiotic which is isolated from the Streptomyces species. It complete the inhibition of the fibroblast proliferation by cross-linking DNA. It acts during the late G1 and early S phases. The concentration used is 0.4 milligram for 1 minute, and the duration can be increased in high-risk BLEBs. The complications include hypotony maculopathy, corneal endothelial toxic, scleral thinning, blebitis, and ciliary body destruction. In 5-fluorouracil, it's a pyrimidine analog antimetabolite. It blocks the DNA synthesis through the inhibition of the thymidylate synthesis. It acts on the S phase of the cell cycle. Intraoperatively, it can be used 25 to 50 milligram per ml for 3 to 5 minutes. FFSS study, it was used post-operatively twice BD 5 mg FU injection for first 7 days, and then once daily injection from 7 to 14 days. The complications include its corneal epithelial erosions, as it's epithelial toxic, and increased risk of late onset BLEB leak. In an in-house study of comparison of low-dose intraoperative mitomycin C versus 5-fluorouracil in primary glaucoma surgery, it was found that low-dose intraoperative mitomycin C and 5-FU can provide control of IOP in primary trabeculectomy, and the 5-FU group showed more non-ischemic BLEBs.
MMC or 5FU?
MMC.
MMC is almost 100 times more toxic to the fibroblasts compared to 5FU. So you have to be very careful when you're using MMC. Can lead to very avascular BLEBs with attendant complications. This particular study, this was in patients who required bilateral surgery. One eye MMC was used and the other eye 5FU was used. So you could have a direct comparison. We have only 6 months follow-up in these patients. The IOP control was similar between the two groups, but MMC had more diffuse and avascular BLEBs.
So this is a video of how we apply the mitomycin C, which are used using sponges. Appropriate dose and duration should be used. The number of sponges which are used should be counted and removed. There should be careful placement of the sponges. Larger sponge area should be used so that a larger diffuse BLEB is formed, and adequate wash should be done. Now, anti-VEGF and trabeculectomy. Studies have evaluated the use of bevacizumab or ranibizumab as an alternative or adjuvant to the MMC at the time of trabeculectomy. Route of administration can include topical, subconjunctival, intracameral, or intravitreal. Reports have shown difference in the BLEB morphology in eyes treated with anti-VEGF agents. Early post-operatively, there was less vascular and more diffuse BLEB compared to MMC. However, the effect appears to fade, and long-term outcome shows more vascularity and higher IOP when they were used as a single agent compared to the mitomycin C. In a study by Su et
One second. Any other way that mitomycin C can be applied? Fellows?
Injection subclinic.
So how do you give the subconjunctival injection? What dose?
1/10 of normally we are using like 0.1 ml or 0.4 mg per ml.
Usually it's 0.1 ml of 0.2. You can use 0.4 in 0.1 ml of a 0.4 solution. But how exactly do you give it? And what do you do? What needle do you use? A 30 gauge needle. Then what do you do?
Wait for 10 minutes.
No, you don't have to wait for 10 minutes. 10 minutes is for needling. But for a trabeculectomy, you usually wait for 1 minute, but you have to use a muscle hook to drive the mitomycin away from the limbus so that you get a more diffuse spread and more posterior spread. You don't want it to remain anteriorly because then you can get wound leaks. So you spread it as much as possible and spread it posteriorly. Yeah.
In a study by Su et al. Also found that there was no benefit of adding bevacizumab to trabeculectomy with 5-FU. The adverse effects related with anti-VEGF agents are vitreous hemorrhage, lens injury, retinal detachment, CRAO, morphological changes in the corneal fibroblast, and endophthalmitis. Now, the Ologen implant. It's a disc-shaped biodegradable collagen matrix implant. The composition of it is 90% lipophilized collagen with 10% lipophilized glycosaminoglycans. glycans. The pore size is 10 to 300 microns. It's biodegradable in 90 to 180 days. It acts as a spacer by mechanically separating the conjunctiva and the episcleral surface. It guides the fibroblast to grow through the matrix pores in a random fashion, reducing the scar tissue formation. In a study by Senthil et al., they found that the success of trabeculectomy in eyes with mitomycin C was similar to the eyes with collagen implant. And another study by Sen et al. Concluded, which was conducted as a prospective randomized controlled trial comparing the mitomycin C combined with collagen implant versus the mitomycin C used alone as an adjunct in trabeculectomy. They concluded that the addition of biodegradable collagen implant, that is collagen, does not improve the efficacy of the MMC augmented trabeculectomy in a primary adult glaucomas. Now, the creation of the scleral flap. It usually 1/3 to 1/2 of the scleral thickness flap is created in the superior sclera, posterior to the limbus. The scleral flap is centered at 12 o'clock to help prevent the postoperative BLEB exposure and dysesthesia. Common flap shapes include triangular, rectangular, or trapezoidal. Most commonly, a triangular scleral flap of 4 by 4 mm base at the limbus is used. The scleral flap is usually dissected forward until at least 1 mm of the bluish-gray zone of the peripheral cornea is exposed. So, in this video, we can see we are creating a scleral flap, which can be made by a Barrett-Buckle knife or as well as a guarded knife. A half thickness to 3/4 thickness scleral flap is usually dissected until we can see the bluish-gray clear cornea. And the dissection should be uniform. So the complication which can be related at this step, we can have a superficial dissection as well as a deep dissection. In superficial dissection, there might be a flap tear or a total flap amputation. In flap tears, the flap is then sutured to the anterior limbal tissue and create a new flap more posteriorly in a deeper plane. In a total flap amputation, we go for a donor scleral tissue reinforcement or a glaucoma drainage device. The deeper dissections are prone to posterior premature entry. Special
Wait,
care.
1 second. Why do you have to go straight away for a glaucoma drainage device?
Ma'am, if only one site is remaining.
No, you can use a donor scleral flap or a donor patch graft. You don't have to go for a drainage device on the table.
In deeper dissections are prone to the posterior premature entry. Special care should be taken in fashioning the flap in ophthalmic and high myopic eyes. Visualization of a dark uveal tissue through the scleral bed indicates a very thin underlying sclera. In these cases, if it occurs, a balanced salt solution or a viscoelastic is injected to deepen the anterior chamber, and a superficial lamina is then dissected anteriorly into the clear cornea. As in this figure, we can see in the left figure, we can see the scleral flap tear, which is then sutured. And in this figure, in the left side, we can see a thin scleral flap, which was closed by transport partial thickness scleral flap. The next.
Well, 1 second. Fellows, what precaution do you take for ophthalmic eyes when you're dissecting the scleral flap? Yeah, the limbus is stretched. So what precaution do you have to take? Why is the dissection so important?
Regarding mitomycin concentrations, you have to
No, I'm
use.
talking about the scleral flap. I'm not asking about mitomycin concentration.
Okay.
Huh? Yes, I know it's thin sclera, but that is not the problem. I'm talking about how far you would dissect. What is the issue with ophthalmic eyes? You said thin sclera, you said stretched limbus. So what precaution do we take?
We might land up getting vitreous after.
Yeah, you
punch.
can get a vitreous loss if you have not dissected into the cornea.
Yes.
If your incision is right at the sclera, because of the stretched limbus, you can get vitreous loss. So you have to be very careful. You have to use a crescent knife, dissect into the cornea and make sure that your entry is in the cornea and not at the corneoscleral junction.
The next step is paracentesis. It is done prior to the creating of a trabeculectomy stroma. It helps in providing the entry of fluid into the anterior chamber at any stage of the procedure. For example, for AC wash in case of hyphema or a pigment debris, or provide fluid to assess the flow after scleral flap closure. Next is the creation of the fistula. In this, usually the anterior chamber is entered with a knife just behind the hinge of the scleral flap, and then the Kelly's Desmus membrane punch is used to excise the limbal tissue 1.5 to 255 mm beyond the limbus. The internal ostium should be covered with scleral flap 1.5 mm on either side. So in this figure, we can see we have the punch is not in the center. So there is an eccentric stroma which is being created. So the next step is performing a peripheral iridectomy. The PI should be done directly under the ostium and slightly larger than the ostium. Its purpose is to prevent the iris incarceration into a sclerostomy as well as to prevent a pupillary block. Now the scleral flap suturing. The scleral flaps is sutured with fixed or releasable sutures with 10-0 nylon suture. The closure that achieves mild to moderate resistance to aqueous flow and maintains the AC depth is optimal. Fixed sutures can be placed at the apex or base. Most surgeons prefer to achieve a tight scleral wound closure with a plan to lyse the suture in the post-operative period using argon or diode laser. Alternate to the suture lysis is a releasable suture. Various techniques of releasable sutures actually can be used. Most commonly used is a modified Kolker's technique or a Rootman's technique. So in the video in the left, we are seeing a modified Kolker's technique of releasable sutures. And this is the Rootman's technique. Next step is a conjunctival closure. The conjunctival closure should be a watertight. For for onyx paste, we can use an edge pursue string suture, or we can use a single interrupted suture at one or both ends of the conjunctival flap, or we can use an interrupted horizontal mattress suture. For limbus based flaps, we can use an 8090 vicryl suture, which can be used to close the conjunctiva in a running, locking fashion, incorporating the tenons in alternating bites if the tenons is preserved. So this is a video showing a purse ring suture technique for closing the conjunctiva.
Fellows, what's the most important part of the suturing? Hmm? The knot should be buried. If the knot is exposed, it's going to attract discharge and you can get microabscesses in the cornea. So whatever sutures are applied at the corneoscleral junction have to be buried. And the wing sutures are taken at the corneoscleral junction, not into the cornea.
This video is showing the horizontal mattress suture. So this video shows a surgical technique of a limbus-based flap. You can see the incision is made 10 mm behind the limbus. And rest of the steps are similar to a phonic-based flap. Now, there is a move field safer surgery system which is designed to improve the surgical outcomes for the patient for undergoing the trabeculectomy. For further study, you can actually go to this link. And the next is then adjustable suture. Adjustable sutures were first described by Dr. Peng T. Kaur and were fastened in a bow tie pattern after making 4 throws and leaving as such. It's an alternative to a scleral flap suturing. Specially designed forceps with smooth edges, that is known as cause adjustable suture forceps, is used to adjust the suture tension transconjunctivally in the post-operative period. In their study, they found that this provides a better IOP control than the argan suture lysis as well as ocular massage. So in this photo, you can see this is the forceps specially designed by the Dr. Kaur. Now moving on to the post-operative complications, which can be divided into early and late. The early post-operative complications can further be divided into shallow AC and deep AC. In a shallow AC with a low IOP, can have a flat bleb as in wound leak and choroidal detachment, or can have an elevated bleb and as in a case of excess filtration. Shallow AC with a high IOP can be 3 things: pupillary block, aqueous misdirection, or a suprachoroidal hemorrhage. With a deep AC and a low IOP is an oval filtration bleb, while a deep AC with a high IOP can be a failing bleb, which the reason can be at the level of scleral flap, at the level of the bleb, or at the level of the ostium. We are going to discuss each bit of thing in the subsequent sections. In the late complications can have a bleb leak, overhanging bleb, dysaesthetic bleb, or a bleb-related infection. So the first, with a shallow AC with a low IOP, we should check hypotony with a the video is not working, but hypotony without a visible bleb, a conjunctival bleb leak should be suspected. Sedal test should be used to localize the leak, and the surface of the bleb and the suture line should be tested for the leak. It is managed. Management usually depends upon the size and the position of the leak, appearance of the bleb, depth of the AC, and antimetabolites were used or not. Eyes with a deep AC and a well-formed bleb, a small leak along the suture line heals well, either spontaneously or with a conservative treatment. With the use of antimetabolites, small leaks may not heal, and the surgical closure may be needed. In the conservative management, usually we patch the eye. We start the aqueous suppressants and antibiotic drops like gentamicin and tobramycin. Other measures can be a large bandage contact lens, collagen shield, and tissue adhesives like cyanoacrylate or a Feblen glue. Surgical management is required if medical management fails. Now, the second reason for a shallow AC with low IOP is a serous choroidal detachment. The precipitating factor of a serous choroidal detachment is usually a hypotony. The detachments may further reduce the aqueous flow and start a vicious cycle. Most cases usually resolve on a conservative therapy that consists of frequent topical steroids and cycloplegics with or without systemic steroids, along with the management of the event of the precipitating hypotony. One should rule out the inherent use of aqueous suppressants also. For the surgical intervention, we use choroidal drainage, and the indications are if there is a corneal lenticular touch, large non-resolving effusions, or if the patient is unable to tolerate. The third and the last cause for low IOP with shallow AC is excess filtration, and it occurs as a result of a loose scleral flap closure. The first step is to decrease the frequency of the post-operative topical corticosteroids, aggressive cycloplegia with 1% atropine. Surgical intervention is required if anterior chamber does not deepen within the 5 to 7 days post-operatively. Surgical intervention usually is the deepening of the AC with viscoelastic air or perfluoropropane and flap resuturing. We can prevent this by tight closure of the scleral flap during the primary surgery. Now, the causes for elevated IOP with a shallow AC in the early post-operative period can be a pupillary block, aqueous misdirection syndrome, or a suprachoroidal hemorrhage. In the pupillary block, it's the first differential diagnosis of a raised IOP with a shallow AC. It is difficult to differentiate it from the aqueous misdirection, but iris bombay, which is caused by the pupillary block, usually is associated with a central deep AC and a shallow peripheral AC, and the treatment is usually a laser or surgical iridectomy. The aqueous misdirection syndrome, it's usually caused by the posterior diversion and pooling of the aqueous in the vitreous cavity. Sudden shallowing of the AC following the conjunctival leaks, overfiltration following the suture removal may be the initiating event of the cascade leading to the misdirection of the aqueous. This shallowing causes alternation in the vitreous volume and its compaction, leading to the increase in the vitreous volume and reduced permeability of the aqueous through the anterior hyaloid phase. This leads to the progressive accumulation of the aqueous in the vitreous cavity and uniform shallowing of the AC. The treatment, if the medical treatment, we give aqueous suppressant and cycloplegics, while in surgical treatment, we have to do a pars plana vitrectomy with peripheral iridotomy with zonulohyalodotomy.
1 second, go back. So in aphakic or pseudophakic eye, you can do an anti-YAG laser disruption. But in a phakic eye, you cannot do it unless you have a very large PI and you can see the anterior vitreous phase, which is very unlikely. So in a phakic eye, usually we remove the lens. We do a phacoemulsification with the IOL implantation, followed by a pars plana vitrectomy with a zonular hyalodotomy.
To differentiate between a pupillary block and a malignant glaucoma, in the pupillary block, the PI is usually blocked, and the peripheral AC is usually shallow, and the central there is a central deep AC, and the lens diaphragm is at the normal place. While in the malignant glaucoma, the PI is patent. There is a uniform shallow of the anterior chamber, and the lens iris diaphragm is moved forward. The
1
last
second.
is
Question to the fellows. In a malignant glaucoma, can you get hypopnea or a choroidal detachment?
Yes, ma'am.
So it's not always associated with an elevated IOP. The earlier teaching was that if there's a choroidal detachment, it's a differential diagnosis for an aqueous misdirection. But we have described our own data where we had 6 patients with choroidal effusion who went on to develop an aqueous misdirection. So even if the IOP is low or normal, if all these features are seen, a diagnosis of aqueous misdirection has to be made. You did not mention medical treatment for it, did you? You went straight away into laser and surgery. What is the medical treatment for? What is the initial medical treatment?
Aqueous suppressant and
Why do you use aqueous suppressants?
we want debulking of the vitreous basically, so that iris lens diaphragm. So we basically due to the debulking of the vitreous.
You're not doing a
We have-
surgical debulking. What you're doing is you're reducing the flow into the vitreous. Because what happens when the flow occurs, the anterior vitreous becomes more and more compacted and becomes condensed and dense. So there's no flow of aqueous from across the vitreous phase. So you want to break that cycle, which is why you use aqueous suppressant. So once the flow into the vitreous reduces, then the anterior vitreous phase becomes a little more permeable and the anterior chamber may form.
now the delayed suprachoroidal hemorrhages is usually there is an abrupt onset of pain, nausea, and loss of visual acuity. On examination, there is a peripheral and central flat AC with a loss of red reflex, and there is an appearance of a dark brown dome-shaped choroidal elevations. The risk factors include aphakia, previously vitrectomized eye, sudden decomposition of an high pre-op IOP, hypotony during surgery, elderly age, uncontrolled systemic hypertension, and high myopes. We can prevent this by using preoperative IV mannitol administration in patients who have high preoperative IOP, control of systemic hypertension, adequate local anesthesia to avoid external pressure over the eye, as well as paracentesis and using an AC maintainer in high-risk cases. The surgical small hemorrhages can resolve spontaneously with topical and systemic steroids, and larger ones will require drainage. The indications are kissing choroidal detachment, vitreous incarceration, and vitreoretinal adhesions. The choroidal drainage is done once the liquefaction occurs, which is usually 5 to 10 days, and usually through the inferiorly placed sclerotomy with a constant infusion of BSS in the anterior chamber. Now, the elevated IOP with a deep anterior chamber, the problem can be at the level of scleral flap, which is usually a tight closure of a scleral flap, and the management can be by giving a digital pressure, which is firmly compressing the globe with the index finger over the lower eyelid while the patient is looking upwards. The IOP, the depth of the anterior chamber, and the height of the BLEB should be noted after the digital pressure, and these measures have to be repeated multiple times. If the IOP still remains high, removal of the releasable suture or a laser suture lysis can be considered. And if the BLEB remains flapped with raised IOP in spite of digital massage and laser suture lysis, that means the scarring is at the episcleral surface, and that is the cause of BLEB failure. In these cases, we will have to use 5 FU subconjunctival injections with or without needing in the post-operative period. There can be obstruction at the level of ostium also. This is rare, but maybe due to obstruction due to fibrin, blood, vitreous, or iris. So that's why gonioscopy should be done to look for if there is any obstruction. Obstruction with the fibrin and blood is transient, while the obstruction with the iris or a vitreous strands needs intervention, and usually a surgically enlarging iridectomy is needed in these cases. So in needling can be the video is not playing, but it can be done easily as an outpatient procedure under the sterile condition used on a slit lamp or in the operating theater. A 30 gauge needle is usually passed beneath the conjunctiva about 8 mm from the BLEB and is used to balloon up the conjunctiva. Then we have to wait for 10 minutes, and then the needle is passed subconjunctivally to the BLEB site, visualizing the tip and sweeping the motion. It's used to puncture and incise the fibrous episcleral tissue.
1 second, fellows. Do you think we can use a 30 gauge needle? Yeah, 30 gauge needle we can't use. It's too pliable and it won't be tough enough to cut the scar tissue. So we usually use a 26 or 27 gauge needle. You can even use a myringotomy knife, but that is quite thick. But if there is enough very thick and fibrous capsule, you can use it, but you can't use it with thin conjunctiva. What are the other ways in which needling is done? You said that with this needling, you give post-operative IF injections. What are the other ways, fellows?
With mitomycin C other than 5-FU.
Mitomycin C, how is it used?
The same way, like we have to give mitomycin injection subconj, like 1/10 of the concentrations. Usually we use like 0.1 ml or 0.4 or 0.2 mg per ml.
Where do you inject it? Into the BLEB.
No, away from the BLEB.
You have to go at least 6 to 8 millimeters away from the BLEB. You don't want to inject it into the BLEB because what will happen? It will enter the anterior chamber. So you have to inject it away from the BLEB, wait for 10 to 15 minutes, and then do the needling.
This FFSS study, that is a fluorosil filtering surgery study, it's a randomized controlled clinical trial comparing the success rate of standard glaucoma filtering surgery to the success rate of standard surgery with adjunctive 5-FU treatment. For the 5-FU group, they give 5 milligram of 5-FU injected twice daily for the first to 7 post-op days and once daily from 8 to 14 post-op days with a standard post-op follow-up of 5 years. They found that the 5-FU led to an improvised IOP control and success rates following up all the follow-up periods. That is 48% for the 5-FU and 21% for the standard group at 5 years. The 5-FU group showed a higher rate of late onset filtering BLEB leak and more cases of endophthalmitis.
Can one of the PGs describe how the 5-FU is injected, what precautions you take? One of the PGs?
Ma'am, we have to give it away from the BLEB site and we have to make sure that we're giving it.
First, what do you do? Describe the technique.
Ma'am, we we put topical anesthesia and we also locally touch that site with a cotton swab which has topical anesthetic on it.
Then? Yeah, correct. Then?
Ma'am, then we make sure with our 30G needle we go subconjunctivally itself, not disrupting the tenons basically, and it is away from the BLEB site when we're giving.
No, do we avoid disrupting the tenons? No. The precaution that you take is you go into the subconjunctival space, subtenon space, and introduce the entire length of the needle into the subconjunctival space if possible, so that as you inject, the material will be away from the injection site. And you have to place a cotton pledget over the injection site so that when you withdraw the needle, the material doesn't come into the tear film, because that will cause the corneal epithelial toxicity. So when you're actually injecting, if the tenon is quite thick, you can weave in and out of the tenons so that the path that you create is irregular, so that it won't flow back into the tear film easily. So if you take these precautions, you reduce the corneal epithelial toxicity by almost 90%. You can inject it near the BLEB, but the problem is if you have a subconjunctival hemorrhage, it will enter the area of the BLEB and increase the risk of scarring.
The next is the encapsulated BLEB, also known as a tenon capsule cyst. It is characterized by a highly elevated, smooth dome-shaped BLEB with large vessels around it, with no microcyst. It's typically developed within the first 2 months of the surgery, and the risk factors are of a long-term topical glaucoma therapy and a limbus-based flap. the usual management is resume the anti-glaucoma medications, that is suppressants, and if it fails, we can do needling. In a study by Fay et al. Suggests that a single needling procedure of an encapsulated BLEB offers no better intraocular pressure control than medical management. Then the other
Wait 1 second. Why do you use aquasuppressants? How does an encapsulated BLEB occur, fellows?
It's basically due to the irritant aqueous, which contains more inflammatory mediators like VEGF, which comes in contact with the fibrous capsules which formed around the BLEB. So it proliferates the fibroblastic activity and forms the thick fibrous capsules and localized encapsulated BLEB. So we have to decrease, slow down the contact of the red aqueous to the fibrous capsule. So that's why we are giving aquasuppressants.
Yeah, the fibrous capsule becomes more and more thick and impermeable. So the aqueous flow does not occur. You don't get a microcystic BLEB formation. So you have to reduce the pressure within the cyst so that the cyst wall becomes more permeable. That's why they used to start medical treatment with aquasuppressants along with the topical steroids. There is a lot of studies which have been done comparing medical treatment with needling. And they claim that medical treatment is as effective as needling. But it's not necessarily true. Nowadays, needling is part of the post-operative titration that we do. So when we find a BLEB which is failing or we find an encapsulated BLEB, we do go ahead with needling. And that, because once you start glaucoma medication, you're acknowledging that your surgery has failed. Because what you're trying to achieve is control of intraocular pressure without glaucoma medications, at least for some time, 1 to 3 years. 50% of the efficacy of a trabeculectomy reduces in 3 years' time. So you want it to function at least for some time without medications. So if the surgery doesn't appear to be working and the scar tissue formation occurs by the 3rd to 4th week, the pressure starts going up, then needling is usually done. Yeah.
The other early post-op complications may be uveitis, which can be managed with topical corticosteroids and a mediatric cycloplegic. The formation of a Dellen, which is usually treated with lubricants, and ocular decompensation retinopathy. There's an ocular decompensation retinopathy is a term that is used to describe the eyes of the patients who develop intraretinal hemorrhages immediately after trabeculectomies, especially high preoperative IOP with a sudden decompensation and an alternation in the configuration of the lamina cribrosa, which may lead to retinal veil obstruction and cause this complication. This is more common in children. The late post-op complications may be a chronic hypotony, a late failure of filtration, a late onset BLEB leak, blebitis, an overhanging filtering BLEB, or a dysaesthetic BLEB. Chronic hypotony is usually said when the IOP is less than 5 mm of Hg for more than 3 months. In hypotenuse maculopathy, the risk factors are young age, high myopia, and pre-op use of carbonic anhydrase inhibitors. The typical fundus finding is a macular striae radiating for the fovea, often with one or more extensive choroidal folds, with tortuous retinal blood vessels. The prevention can be done by using a minimal use of the antimetabolites as well as a tight wound closure. The conservative management is using of a bandage contact lens, while a surgical intervention, we can do a conjunctival compression sutures, resuturing of the scleral flap, and an autologous blood injection. Now, dysaesthetic BLEB. The symptoms are common with the nasal or large BLEBs or BLEBs extending to the cornea. It is associated with the superficial punctate keratopathy, tear film abnormalities like Dellen formation, and ocular surface irregularities. The patient have symptoms of foreign body sensation and visual disturbance. It can be treated with the argon laser, with a compression suture can be used to reduce the height of a large elevated BLEB, and in the surgical excision, we can excise the dysaesthetic BLEB. The late BLEB leak is usually due to a thin-walled BLEBs that are common with the anti-metabolite supplemented trabeculectomies. The frequency of the late BLEB leak ranges from 1.8 to 10%. It is usually treated with autologous blood injections, aquasuppressants, antibiotics, patching using of a large diameter BCL, tissue glues like cyanoacrylate and fibrin glue, and autologous free conjunctival flap with or without scleral patch graft. Now, the BLEB-related ocular infections. In a trabeculectomy, the infection usually starts at a subconjunctival space and can go into anterior chamber or a vitreous cavity. The onset of the infection may vary from a few days post-surgery to also reported as 20 years following a filtration surgery. The risk factors include thin-walled blebs with leaks, myopia, the presence of releasable sutures, concurrent respiratory infections, bleb located at the inferior limbus, unguarded filtration surgeries, and diabetes mellitus. The incidence in the incidence which was found in the trabeculectomy arm of TVT study was 5%, while in the FFS study it was found of 0.9 to 1.9%. The usually common symptoms which the patient present is of history of a red eye with a discharge. On examination, the bleb may have a milky white appearance with a loss of clarity and may be associated with a bleb leak or hypopion or a vitreous reaction. It is usually classed in three stages: stage 1, stage 2, and stage 3. Stage 1 is when the bleb is involved, stage 2 when there is stage 1 plus anterior chamber involvement, and stage 3 when there is stage 2 plus vitreous involvement. In the usual management in the stage 1, that is blebitis, is likely to respond to the intensive antibiotic treatment with more favorable outcomes. When there is an involvement of the anterior chamber or the vitreous cavity, a fluid tap should be taken and sent for microbiological examination, and topical and systemic antibiotics will be needed and will be done according to the reports of the tap. A full-blown endophthalmitis will need aggressive treatment with a form of intravitreal injections as well as vitrectomy. These are my references. Thank you.